I'll start with one question, kind of it was directed towards Elaine, but I'll give it to the group, and then I'll let Anne take over for the next. But someone asked, once LGS is well established, is there still recuperation of cognition possible by controlling seizures, even later, perhaps in older teenagers and adults? And I think this is an important question as we think about both the mechanisms, but also for treatment. Is there a window? Do we know? How do we figure that out? So I'll let Elaine start because it was directed to you, but I'd love to hear from the others as well.
Yeah, no, that's a great question. I think, when we think about this, it really is sort of the concept of the developmental encephalopathy, the underlying etiology, and then the epileptic encephalopathy, which is the encephalopathy that's being made worse by the frequent seizures and our very abnormal EEG. And I think certainly as a clinician, I do think that we can improve things for many patients if we can get them to a period where their seizures are controlled. I think that there is, though, if you have long-standing severe seizures for a long period of time, particularly during a very important developmental window in early childhood, even if you do get, reasonable control of seizures, and that's very challenging in LGS, I think you still can't get back everything. But I think certainly if we can improve seizure control, we often do see the patients become brighter, and some of that is probably improved seizures. Sometimes we can reduce other medications, sort of the polypharmacy that is also contributing to a lot of sedation and things like that.
Yeah, and if I could dovetail on what Elaine just mentioned, clinically, I've seen that as well. I mean, I don't know how much evidence is out there for that, but sometimes when we get the seizures under control, I get this phenomenon where I say, well, welcome, and I want to introduce you to your daughter or your son, because for the first time, they're alert, they're cognitive, so their more true personality tends to come out, but that's because they're not as post-ictal is my theory behind that. And so they're having less frequent seizures, therefore they're spending less time being post-ictal, and therefore doing better.
One thing I would like to say, though, is and I've seen that a couple of times, you get improved seizure control, but sometimes behavior worsens. I don't know if other people have seen that as well.
I would agree. I was going to say that's the challenge Anoop just mentioned. Sometimes we say, yes, welcome to your son or daughter that's not sedate all day. And the family's like, oh, we like the sedate child much better. They're easier to take care of, or the sedate adolescent. So yeah, that sometimes is the downside, if you will. But of walking families through that and making sure they understand it. Yeah.
We thought we'd ask some general questions, and I'll invite all of the speakers to jump in as you feel appropriate. But one of the questions that we had is, can we think about preventing LGS by identifying children who are at risk early? And Anoop, you mentioned this in your talk, that sometimes you just know it's coming. And to break that down a little bit, what is it that people are saying that they see that tells them that a child is heading toward LGS? And beyond that clinical sense or specific things that might be symptoms or signs, are there objective biomarkers, EEG, or other biomarkers that we should be looking for in young infants and children with epilepsy that are harbingers of LGS to come? And are there biomarkers that we should be using to screen in the future, maybe all children or groups of children at risk with developmental delay and so on? So I'll open that up to all of you. I think each of you would have something to comment on in that regard.
Yeah, I mean, I want to go back to Elaine's comment about neuroinflammation, because I feel if the idea behind it is potentially that makes things worse, then could you augment the future by doing some more, anti-inflammatory treatments, like some steroids and high-dose steroids? Zach Greenspan has a nice proposal around this idea. I don't know if he's available to talk specifically about it, but the idea is that could you identify children either through biomarkers or through treatment failures that then can be, given a treatment like steroids again, and seeing if that could be augmented. I don't know, Zach, if you want to comment more on that.
Thanks, Anoop. I wasn't on the panel, so I'll speak more about it later. But the idea is find patients who are early and hit them with steroids. It works for infantile spasms. It works for ESCS. So maybe we need to be using that approach more frequently.
Yeah, if I can make a comment, I've had a couple of presentations of ACTH or high-dose steroids on established LGS that started as focal and became secondary And it was even years later, and we were able to convert them back to focal and then do surgery locally. So about 7 out of 15 patients responded, and they were years out. And I try to hit them early if they're not responding. But yeah, you can't get ACTH like we used to because of the changes in how they, since they got FDA approved, they're no longer, it's only for infantile spasms. It's almost impossible to get that. So I have to use high dose prednisone or Solumedrol or other things, but I'm not sure, but I agree. I think early augmentation of that, I've actually seen it work and change the EEG. And I think we don't ask people who had infantile spasms if they respond to steroids. It may be worth going back to if nothing else is working, in my experience.
I saw that Martina Bevan is here, and this conversation sounds very much like what she is doing in the PREVENT trial, specifically with tuberous sclerosis, and that's to prevent infantile spasms. But I think we might learn a lot from what she and her colleagues have done there and apply that, adapt and apply that for Lennox-Gastaut syndrome.
Hi, this is Martina. Let me put my video on here. Yeah, I appreciate you asking that question. I think with TS, we're at a luxury in terms of it's so focused and disease specific. And also the advantage of being able to identify these babies prenatally in probably 2/3 of the cases. So that gives us a leg up on terms of anticipating engaging with the families in the nursery, also making the diagnosis within the first 4 weeks. And then the EEG, I think where you've seen the changes in clinical care is the EEG really being done either in the nursery or in that first 6 weeks of life. So you have a baseline. And then moving forward, that we follow them longitudinally, and the EEG is really the pivotal diagnostic test that really, you can really see the evolution of the epileptogenesis over time. And I think that's really changed our awareness of the disease, as well as the progression and knowing which children are at risk for refractory epilepsy. It also has made us much more aware that it's just not infantile spasms. And many of these babies have focal seizures that when they're very young are almost a negative phenomenon, where it's what they don't do, or they stop movement, or you see a subtle deviation of the eyes. And I think with the implementation of video monitoring or even video EEG in the lab has really educated us that the spectrum of what we're seeing is much more than we thought about probably 5-6 years ago.
Thanks, Martina. I mean, that in a way related to what are the early biomarkers question is another question that came up, which is from Kelly Knapp. What are the first signs? When do we call the clinical scenario that a child is undergoing? When do we finally call it LGS? We have all these criteria, but are there, what are the first indications, and when are we finally giving that label to a child? And the label's important for some of the reasons we talked about, but particularly as we're thinking about not just classification, but clinical trials, it is going to be important. So when do people think it really starts, both from a biomarker and data perspective, but also what's going on with the networks in the brain that's changing from a focal epilepsy to an LGS?
Right.
Yeah, I think. Go ahead. Sorry.
I was going to just mention this. Jurian Peters is on this Zoom call or Zoom meeting, and he's one of the EEG reviewers for PREVENT. And I think just in general, in looking at biomarkers and attempting to identify them and standardize them, I think one of the things we learned is before you even set up a trial is we spent a lot of time making sure that we had very high inter-rater reliability between the readers, and we would go back and then recheck if there was drift, why there was a difference. And I think there's some movement now to use AI as part of this. So I think, really where is the human element as a reviewer, and what role AI has in this, I think are important questions. And I think in the long term, when PREVENT is over with, and Brenda is also on this call as well as Jurian, we've talked about once we figure this out, because there'll be more biomarker data confirmed from the PREVENT, is how is that translated into routine clinical care for clinicians, so they know when you call it really an identifiable biomarker, and that really puts the baby at risk for epilepsy in the ensuing days or weeks.
We had a few patients in the TASRN trial or observational study as well, where you could just see the EEG become more and more abnormal over time. And 6 patients of the 40 that had very intense serial EEG monitoring were pre-treated. So we were basically shooting our own observational trial in the foot, because the clinician said, well, this is impending spasms, even though the patient wasn't clinically not having spasms yet. And in one case, we couldn't reach the parents, and by the time I reached them, the spasms had started very subtly. So I agree that you sometimes, just by clinical experience, you can see it coming, and it would be really nice to translate this clinical experience into biomarkers that are objectively measurable and reproducible across centers.
The other thing that I'll mention is, these are maybe biomarkers for epilepsy, but the other one is biomarkers for the progression to autism spectrum disorder, to profound cognitive impairment. And people have already started to look at those. You can look at other kind of computerized, you look at the same EEG we're looking at visually, and you do computer analysis on it to look at connectivity and other features. That's been looked at, for example, in tuberous sclerosis, where you can look at infants and be pretty predictable of which ones will develop autism later. A couple of small studies that have looked at that. That's not quite ready for prime time because of the commercial availability of those products, but that should get there, because if you look at cardiology, for example, you look at a standard EKG, it may look great, but then if you put it through kind of computer processing, you say, oh, you have, T-wave alternans, you're abnormal, you're at high risk for cardiac sudden death, even though the visual inspection looks totally normal. So I think we've got to think about beyond just EEG for seizures, EEG for measure of cognitive function, and looking at other ways we can utilize it to look at connectivity and other measures, because those are actually very important to our families as well, obviously.
And I'll
One of the
touch on that
ideas-
a little bit as well in my talk.
Oh, you are? Yeah. Because one of the ideas we've talked about through like our PERC subgroup is looking at that first atonic seizure as a clinical event, and then use that as a trigger point to look backward and then slightly forward to see what sort of features and potential biomarkers exist, both either clinically or electrophysiologically, et cetera. Because and I'd love to hear what Kelly has to say as far as, you sometimes see that evolving picture, it's similar to what you guys mentioned with spasms. You can also, I think, see some of that in the first development of the slow spike and wave. And when you start to see some of that with maybe a little GFP at bay, then you know where this is going. And I'll tell you, it always ends up the same spot. It ends up with a clinical semiology of multiple seizure types and fits the spectrum of Lennox-Gastaut. And so I think those are potential other learning opportunities. And then, using what Jim says, maybe if we can quantify that or somehow, look at it from that standpoint, we can maybe learn some of those biomarkers.
Anoop, if I can just riff on what you just said, one of the issues that I'll talk about later is that when that EEG pattern first emerges, sometimes those kids aren't seizing, that they're actually in a period and they're in that gap where they're, the spasms have ended, but the LGS hasn't really started. And so you've got the slow spike and wave pattern building up, but clinically you've got control of the seizures. And so it may be that we're at there's sort of this cognitive block that we have where we see it evolving, but the seizures are under control. And so there may be a reluctance for us to be aggressive in our therapies. And so that when a conceptual obstacle like that is identified, it's also an opportunity for further study and maybe an area for us to pursue.
Well, we have a few minutes left, and we were thinking we would ask our 4 speakers who've really laid the stage for all of the sessions to come in terms of clinical research and bench research that can reflect this condition we call LGS. We wanted to ask everybody to project forward. We're going to hear in those upcoming sessions about progress we hope that will be made in clinical and bench research to move towards specific therapies for specific diagnoses for patients with LGS. what is the future going to look like? If you now that you've laid the stage, where do you want us to be when we have this conference again in 5 years, and what will diagnosis and treatment look like? So maybe we could go in the order of our speakers and start with Elaine.
Yeah, so I think just sort of, identifying this early and identifying markers that are highly predictive towards development of LGS, and and potentially then looking carefully for things that are modifiable at that stage before somebody develops the full-blown LGS. So, there's a neuroinflammation component. We've already talked about it, and I think there's some interesting case reports out of Australia that looked at connectivity and networks and sort of the impact of early surgical resection in candidates. So I think just trying to identify these kids earlier, really looking at what are the important pathogenic pathways, and knowing how we can then intervene, before they have 10 years or 15 years of drug-resistant seizures and slow spike wave and a very abnormal EEG.
Yeah, I guess I'll go next. My answer to that, which is a really great question, I would say is focused on genetic etiologies and what can we learn about modifying therapies for those genes. And if we, again, I feel the first step is to really understand each of those genetic links to LGS and see what these patients have in common, and then how potentially the gene modifying therapies may impact the long term. I think is really an opportunity that I'm excited about in 5 years.
Sorry. I was just reflecting on what Martina had been saying about why they have a leg up on where we are in the LGS community, and being able to identify children in the NICU or newborn care and enroll them at that point, and they're dealing with a relatively homogeneous disease. So part of what I think might be helpful is to clamp down on, I'm an epidemiologist, the epidemiology of this from the get-go. We've done that a little bit. I think, Elaine, you very kindly mentioned the work we did in Connecticut with the Connecticut study, and pointing out that in children with onset under a year of age, 13% of them, it's a small numbers, but 13% went on to get LGS, 10% if they didn't have spasms. There are pockets of high-risk patients, and if we could understand that better through the lens of 21st century diagnostic evaluations, our work was done back in the 1990s. I think that would be fascinating. Identify who the high-risk group is, and then, as Zach said, you're a little bit nervous about being too aggressive in someone who doesn't have seizures, but that's exactly what's happening in the PREVENT trial. They know it's going to go where it's going in terms of going to spasms, even though the children don't have spasms yet. So they're pre-treating, and that we just need to get the knowledge about Lennox-Gastaut clinically on the same footing.
All right, and I would agree with all those. I think, as I alluded to in my talk, that hopefully things that will change, that will help our patients. I think device therapy expanding to other devices for a lot of our families realize their children and adolescents that grow up to adults are on drug therapy, but they really would like them to be on less. They're frustrated because they're giving them all these medicines and they're still having all sorts of problems. So anything that allows us to minimize that, I think, would be huge for a lot of these families. But I really think looking at all the other comorbidities, which, really for many of our really devastating childhood epilepsies has not been looked at to say, can we tailor therapies to help some of these symptoms in this population? They're all tested in normal, folks, but not in these folks. And can we maybe direct therapies to help with some of the comorbidities? Because that's huge in this group. And I would hope we see improvements in that area.
Great, thank you all. I'm going to go more pie in the sky. I'm not a speaker, but I'm just going to say I think pie in the sky goal, right, is ideally you don't have that first seizure, but I think the earlier we can intervene in this process that we're trying to understand, the better, right? We want to prevent anyone from ever getting there. And I think thinking over the next 2 or 3 blocks of speakers about how do we understand that subway path, right, to LGS, and then how do we get at each of those stations and push it back farther and farther so that we never get there would be great. I'm going to ask Tracy if she has any couple last words, although we have one hand raised. Sandy, we'll do a real quick question or comment, and then I'm going to ask Tracy to wrap up before we go to lunch or break.
Thank you. Thank you for this conference. It's amazing. And really just kind of wrapping together what a lot of my collaborators actually on the speaker panel today, Ann Berg and Anu Patel and Tracy Dixon Salazar are coming together in our multi-center initiative based around a PCORI grant to look at timing of intervention and the outcomes on timing of intervention, and also engaging stakeholder families to help us understand the journey so we can lower the barriers to care. And of course, I'm biased as a neurosurgeon to really understand how we may be able to help that access to care, so that, as Jim said, really understand the role of devices. They are getting better and better. The safety profile is better and better, and the effectiveness is actually quite good. So how do we actually help more kids at the right time and help get that message out that this is a very viable and very good option for treatment of seizure burden, quality of life, and even with SUDEP implications.
Thank you, Sandy.
Thank you so much, Heather and Anne, for a great session. And thank you to all of our speakers. I hope that, probably not 5 years from now, but I hope that as we start to think about new treatments for LGS, we also start to think about treating the underlying mechanisms of the brainwaves. If we can map down a sleep spindle or features of non-REM sleep down to the brain structures that are involved in them and the channels that are involved and the pathways that are involved, and can we target, those areas of possible. But I also hope that we're starting to think about prevention. If you can have a gene therapy early on, or if you can have a prevent trial, or if you can stop the seizures so that it doesn't progress to LGS at all, then we definitely would want that as well. So I hope you guys will come back. We're gonna have an hour-long break right now. I hope you guys will come back. We're gonna be talking about clinical research that's going on in LGS and where the gaps are, what we would need to do in order to move things forward to find disease-modifying therapies. So with that, I will say thank you so much again to the amazing speakers. I've gotten a lot of great comments on how wonderful the discussion has been so far. And we will see you guys back at 2 p.m. Eastern time. So 2 p.m. New York time. All right, thank you guys. We'll see you then. For those of you on the Zoom, you can just mute and turn your camera off if you want, rather than logging out if you'd like to. So.
Thanks, Tracy.
Great, thank you guys. Great job, Anne and Heather.
Thanks, everyone.